The agenda will be as follows. Talk about the importance of early initiation of enteral feedings. Enteral feeding advancement, how fast? Gastric residual measurement. Enteral feeding while using vasoactive agents. Enteral feeding while on therapy hypothermia. And glycerin suppositories and enemas. I'd like to start with showing a picture of this gentleman. His name is Richard Feynman, and he's a Nobel Prize winner in physics. And in addition to being the Nobel Prize winner in physics, he has had some very famous quotes that are highly meaningful. And I'm going to give you some of these quotes. First, we must be careful not to believe things simply because we want them to be true. No one can fool you as easily as you can fool yourself.
Mm-hmm.
A dogma is a principle or set of principles laid down by an authority as incontrovertibly true. And tradition is a belief, principle, or way of acting that people in a particular group have continued to follow for a long time. We have many dogmas and traditions in neonatal intensive care. And these are some that I would like to talk to you about in this very brief lecture. We have many excuses to withhold enteral feedings. And these are some of the excuses that have been used in the past. Low APGAR scores, umbilical artery catheters, apnea and bradycardia. The baby is on mechanical ventilation. The baby is receiving CPAP. The baby is receiving vasoactive drugs. And we have this concept that TPN is available and babies grow just fine on TPN, and that there are no negative consequences of TPN. Well, all of these excuses and factors are not true. They are not based on evidence. Why do we take these particular excuses so seriously? Well, we are afraid as neonatologists. We are afraid of this. This is a baby who developed a very distended abdomen, went to surgery, had a completely necrotic bowel, and ended up dying from this necrotic bowel. And feeding is one of the concerns people have had through this past several decades, that this may actually be causative for the development of necrotizing enterocolitis. Evidence that we have been accumulating over the last several decades suggests that this is really not the case. Well, we do know that IV nutrition is critical, but why is enteral feeding important? Let's begin with showing you the picture of Elsie Widdowson. Elsie Widdowson is a very well-known nutritionist from the UK. And Elsie Widdowson did some work on piglets. And one of the things she showed was that the suckled pig's duodenum gains 42% of its weight in the first 24 hours after birth. If the piglet is not suckled, if there is not food in the gastrointestinal tract, this growth does not occur. This is something that is called the trophic effect of food in the gastrointestinal tract. Now, Dr. Widdowson's studies were done on piglets. What about the human premature infants? What happens when this baby that we see in this picture is not enterally fed? And how fast can enteral feedings be advanced? In the mid-1980s, a study was done by Dr. Alan Lucas in the United Kingdom and published in Active Pediatrica Scandinavia, where there were 5 GI hormones that were evaluated in premature infants. And the effects of feeding were evaluated in these premature infants. These bar graphs show each one of these GI hormones: enteral glucagon, gastrin, neurotensin, motilin, gastric inhibitory polypeptide. And this is the level that we see right after birth. This is the level that we see at 6 days if the baby has not been enterally fed. So we see either a decrease or no increase in these hormones. But what happens when the infant is enterally fed? Even if the infant has respiratory distress or if the infant is well, this is what happens. We see a marked increase in these plasma GI hormones secondary to feeding by the enteral route in these premature infants. This is important. So, for example, motilin is a hormone that is involved with stimulating motility of the gastrointestinal tract. This is a very important function to be able to get food through the gastrointestinal tract, to propulse it forward so that the digestive and absorptive processes can occur normally, and so that waste can be eliminated from the gastrointestinal tract. What about the liver? What happens to the liver if the infant is not fed by the enteral route and only getting TPN? Well, this is what happens after only 7 days of TPN versus enteral feeding. These are piglets who are fed by the enteral route, and these are piglets who are fed only by the intravenous route. And you can see the color of the livers are very different. This is very pale. And on microscopic section, the TPN piglet shows ballooning of hepatocytes. There's fat staining. There's glycogen staining. These are all markers of liver injury after only 7 days of TPN versus enteral feeding. What about gastrointestinal permeability or leakiness of the gastrointestinal tract with enteral feeding and without enteral feeding? This is a study that was done in the mid-1990s by Dr. Chandler and Shulman at Baylor University. And these studies were done on babies with an average birth weight of 1 kilogram and a gestational age of 28 weeks. And the question that they asked was, what happens if you put some food into the gastrointestinal tract, even small amounts of food, usually less than 20 milliliters per kilo per day, process called GI priming, versus TPN only to day 15. These babies, these are human preterm babies who were provided with lactulose and mannitol. Lactulose and mannitol are sugars, and the mannitol is a sugar that passes through the cell itself, whereas lactulose does not pass through the cell. It only passes through intercellular junctions that are damaged or broken down. And if you have a lactulose mannitol ratio that is high, this means that there is increased permeability of the gastrointestinal tract or a leaky gut. And what we see in this slide is that those babies who received TPN only to day 15 had a leakier gastrointestinal tract than those babies who actually were fed a small amount of food. And this is important because intestinal permeability, you see a breakdown of the gastrointestinal barrier on this slide. With increased intestinal permeability, there is the potential for microbes and highly antigenic agents to pass into a highly immunoreactive subepithelium and cause an inflammatory response. And this inflammatory response does not only affect the gastrointestinal tract, it can be a systemic inflammatory response that can affect the liver, the heart, the lungs, the pancreas, and the brain. And so this is an important concept to remember. The gut is the motor that drives systemic inflammation, and if there is not food in the gastrointestinal tract, there is a higher propensity to have a gut-derived inflammatory response. This is a study that was done several years ago and published in PLOS ONE by Dr. Konakova and Drs. Cami Martin. And this study was done to evaluate morbidities in babies who were fed early versus late. And the morbidities can be seen in this column here. NEC, retinopathy of prematurity, chronic lung disease, periventricular leukomalacia, IVH, and all of these comorbidities together. Early feeding was considered to be babies who were fed before 4 days after birth, and late feeding was after 4 days. And we can see that all of these comorbidities are lower in the early fed group compared to the late fed group, suggesting that the inflammatory response from the gastrointestinal tract may have actually been related to very significant morbidities these premature babies.
Yes.
We also know that the microbes in the gastrointestinal tract differ in those babies who are enterally fed versus those infants who are fed only by the intravenous route. And this is a slide that depicts what happens to certain phyla of microbes in the gastrointestinal tract in those infants who are given only TPN or those infants who are also enterally fed. And these colors, and I point to the bar graphs over here, represent different phyla of bacteria. And here in the control infants, it is seen that this green decreases. These are the proteobacteria, and the blue increase. Whereas in the TPN nourished babies, the green stays high and perhaps even increases over time, whereas the blue is somewhat similar. What do these depict? Well, the green are the proteobacteria. Proteobacteria are a phylum of bacteria that constitute Klebsiella, E. coli, Pseudomonas. These are gram-negative bacteria that have a lot of lipopolysaccharide in their cell wall. And so with TPN, we tend to increase those bugs in the gastrointestinal tract that have a lot of lipopolysaccharide, which can stimulate the inflammatory response. This is not the case in the control babies. In fact, in the control babies, this blue increases, and these are the firmicutes. These are the largely gram-positive bacteria that produce short-chain fatty acids, such as acetate, propionate, and butyrate. study is that this was done on a large population of preterm infants, most of these preterm infants being less than 1,500 grams or less than 32 weeks gestation. And we do know that one size does not fit all. We need to think in a more nuanced manner, more precision-based manner, because we do know that there are certain babies who can be fed faster than 30 milliliters per kilogram per day. And this is a study that was published a few years ago in Neonatology by Dr. Sushma Nangia from New Delhi, India. And the title of her paper was Early Total Enteral Feeding versus Conventional Enteral Feeding in Stable, Very Low Birth Weight Infants with a mean gestational age of 31 weeks. And it was found that if you have two different groups, early total enteral nutrition feeding group, where you were able to get these babies up to full enteral nutrition within the first 2 to 3 days after birth, compared to conventional enteral nutrition, where you increased the intake at 20 milliliters per kilogram per day, there was a difference in the primary outcome variable. This is the postnatal age of attaining full enteral feedings. Those babies who were given early total enteral feeding, they reached this outcome at 6.5 days, whereas with conventional enteral feeding, it was 10 days. And if you look at some of the secondary outcomes, which include morbidities, there were less morbidities in the early total enteral feeding group than in the conventional enteral feeding group. So this tells us that there is one side of the spectrum of the one size does not fit all, that where babies can be fed considerably faster than 20 or even 31 milliliters per kilogram per day. Now here we have a 25-week gestation premature infant on CPAP, and this infant required intubation. And here's an X-ray on this baby that shows a very distended bowel. There is no pneumatosis intestinalis, there is no portal venous gas. But this is a baby with very distended abdomen, largely because the baby had been on CPAP and there was a lot of air pumped into the gastrointestinal tract. A baby like this was at very low gestational age, may not be able to tolerate a rapid increase in enteral feeding, such as 31 milliliters per kilo per day. So we do still need to use some judgment, even though the prospective randomized studies suggest that overall, these babies can be advanced fairly quickly. What should we be our premature babies? Well, the American Academy of Pediatrics developed some guidelines in 2012, and these have been revised, but they're very similar even with the revised guidelines. And I underline here, if mother's own milk is unavailable despite significant lactation support, pasteurized donor milk should be used. Quality control of pasteurized donor milk is important and should be monitored. Well, this is sometimes not something that is done in certain parts of the world. Donor milk banks have not been developed in all parts of the world for various reasons. But I think that it's important to recognize that donor milk is not a panacea. Donor milk has some real shortcomings. Now, when a baby is still in the uterus, that baby is getting approximately 4 grams per kilo per day of protein. The extremely low birth weight infant, if we look at the protein content of donor milk, the extremely low birth weight infant would require 330 milliliters per kilogram per day of term donor milk to meet this requirement. This is certainly not readily possible in many of our premature babies. We also have problems with calcium and phosphorus, not only in donor milk, but also in baby's own mother's milk. This is something that happens in too many of our premature babies. And here what we see is a fractured fibrous, and the bones are very thin. The requirements of calcium and phosphorus, as seen in this column, are very high in these premature babies because they are undergoing such rapid growth and bone accretion. Human milk only supplies this amount of calcium and phosphorus, which is about 1/4 that of what is actually needed. So fortification is necessary. If we use a term formula, we are still not reaching this amount. So we have to provide fortified human milk or a special preterm formula with larger amounts of calcium and phosphorus to provide this amount of calcium and phosphorus to these babies. It's also important to remember that many of these babies are getting steroids. Many of these babies are getting diuretics, and this also exacerbates this problem of osteopenia and fractures in bones in our premature babies. So fortification is important. And if you take the example of a 26-week preterm infant 1 week after birth who is on 50 milliliters per kilo per day of own mother's milk, we should consider fortification of feedings with fortifier that provides additional protein, calcium, and phosphorus between 50 to 100 milliliters per kilogram per day of enteral feeding. We also have to remember that donor human milk is not a panacea. One of the problems is that it is pasteurized, and one of the main reasons for the pasteurization process is to get rid of potentially harmful bacteria or viruses such as CMV. This is work that was done by Dr. Peter Hartman from Australia, and he looked at the effects of Holder pasteurization on the bioactive components of human milk. And we see in this graph that the immunoglobulins are all markedly decreased. The enzymes, such as alkaline phosphatase, are almost completely abolished. Alkaline phosphatase and bile salt stimulated lipase. All the microbial cells, which we think may be potentially important for these babies, are killed by the pasteurization process. And also the cellular material, the immunocellular material, is also killed by the pasteurization process. So the bioactive components of donor human milk are pretty much wiped out by this process. Now, I'd like to just ask you a question, and I want you to think about this. This is a very preterm baby who's on mechanical ventilation and being enterally fed. Baby is being fed small amounts, 2 milliliters of breast milk every 3 hours, and the baby is having 4 cc's of yellow gastric residuals. What do? Well, in the past, we really did not know exactly what to do with gastric residuals. Now, in 2025, we know that it is probably not even necessary to measure gastric residuals in our premature babies, at least not routine. Work that was done by some of my colleagues, and here are pictures of these colleagues. Dr. Roberta Murgas was a neonatology fellow who started a small trial, a pilot study, prospective randomized study of gastric residuals in premature babies, and showed that it was safe to do this. And then Dr. Leslie Parker, who is a professor in the College of Nursing, did a much larger study that was published in the American Academy of Pediatrics, in the JAMA Pediatrics journal. And this study showed that it was certainly feasible to not do gastric residuals, and it appeared even safer to not do the gastric residuals in these infants. The rate of necrotizing enterocolitis, sepsis was the same in both groups, but not doing the gastric residual evaluations resulted in less time on TPN and also decreased time on in the neonatal intensive care unit. So there are some benefits to not doing gastric residual measurements routinely, and we have stopped doing these routinely in our neonatal intensive care unit. And most people that I talk to across the world have also stopped doing routine gastric residuals in premature babies. Here's another case, a 27-week preterm who's being treated with indomethacin for patent ductus arteriosus. Do you stop enteral feedings? Well, this is something that was done routinely in the past. One of the reasons for stopping enteral feedings in a baby like this is getting indomethacin is because it is concerning that indomethacin might actually decrease mesenteric artery blood flow. Well, here's an interesting finding. This is done in animals. This is a study that was done at Baylor, where they looked at superior mesenteric artery blood flow during enteral feeding. This is enteral feeding, very high level of mesenteric artery blood flow. And this is when the enteral feedings were stopped and the baby was placed on TPN. So we see a decrease in mesenteric artery blood flow. So if the same thing happens in our preterm infants, if we are giving indomethacin and stopping enteral feedings, we decrease superior mesenteric artery blood flow even more by doing both of those. Work that was done at the University of California, San Francisco by Dr. Ronald Kleiman and colleagues. And this is a paper that was published in the Journal of Pediatrics titled Enteral Feeding During Indomethacin and Ibuprofen Treatment. The main results showed that infants randomized to the feeding arm required fewer days to reach the study's feeding volume endpoint at 120 milliliters per kilo per day, and there were no differences between the two groups in the incidence of infection, necrotizing enterocolitis, perforation, or any other morbidities. So it is probably safe to feed babies while they are getting indomethacin. Another question that is commonly asked is feeding during hypothermia for hypoxic ischemic encephalopathy. And many neonatal intensive care units routinely stop feedings during therapeutic hypothermia for hypoxic ischemic encephalopathy. And the data for that is certainly has never been shown to be beneficial to stop the feedings. Previously, it was shown that if you look at a couple of different countries, for example, if you looked at Scandinavia versus UK, in Scandinavia, babies were being fed by the enteral route during the therapeutic hypothermia. In UK, they were not, but the incidence of morbidities such as necrotizing enterocolitis were very similar. In our neonatal intensive care unit, we did a retrospective evaluation, and we looked at babies who were enterally fed versus babies who were not enterally fed, and we saw that there was a real difference in terms of the decreasing the parenteral nutrition time, so 7.2 days in the minimal enteral nutrition during the therapeutic hypothermia versus 11.6 days of parenteral nutrition in those babies who were not fed during the hypothermic episode. We also saw that pro-inflammatory mediators at 24 hours and at 96 hours were significantly decreased in those babies who were enterally fed during the therapeutic hypothermia period. There are meta-analyses which have been done to evaluate the effects of feeding during therapeutic hypothermia, and they all have showed that there is no detrimental effect of putting some food into the gastrointestinal tract of babies during their therapeutic hypothermia. Another question that is commonly asked is, does evacuating the rectum and colon with suppositories or enemas improve feeding tolerance and increase necrotizing enterocolitis? And this is a meta-analysis of randomized controlled studies. And if anything, the glycerin suppositories or the enemas actually showed a trend, an increase in necrotizing enterocolitis, and did not really decrease feeding intolerance in premature babies. So to do this routinely is probably not scientifically based. So in summary, neonatology is still a young discipline, and clinical judgment without a strong evidence base remains highly prevalent. Dogmas based on clinical judgment frequently stick, but may not be in the best interest of the patient. We need to constantly question our practices. Evidence-based science provides many answers, but it is not prospective randomized controlled trials take a long time and very expensive. The future will provide new technologies and create augmented intelligence and multiomics for prevention, diagnostics, and treatment. Thank you very much for your attention.
Thank you very much, Joe. Thank you very much indeed. Joe, are you with us?
Yes, I am with you. I can't get the video, but I can hear you.
Okay, thank you very much for joining, and thank you very much for your outstanding presentation. Actually, in Egypt, we still have this dogma regarding there's an abdominal distension, we have to stop enteral feeding, and we have a residual, and we have abdominal distension. How can we convince our junior doctor not to follow these rumors, if I can say?
That's an interesting question because when we first started the studies on gastric residuals, we were afraid that the senior doctors and the nursing staff who had been working in the neonatal intensive care unit for a long time would be very resistant to changing. So before we even started the studies, we worked with our nurse manager, the head nurse from the neonatal intensive care unit, and we had several discussions with the nursing staff, and just explained how we were going to do these studies. And then once the studies were completed, I think that it was very convincing to our nursing staff and our doctors that it's something that we did not have to do routinely anymore. And this is actually something that is now, when I speak at different conferences and ask people if they are doing routine gastric residual evaluations, it is very, very unusual to have people raise their hand and say that they are doing routine gastric residual evaluations. So I think that a lot of discussion and going through these studies that have been done, the studies that we have done at the University of Florida, my colleagues and myself, the ones that I showed you on the slides, there are actually a couple of other studies now as well. So I think that that we have some fairly strong data to show that it is unnecessary to do these and in fact, potentially harmful.
Thank you very much. One of our colleagues said, his question is, what are your views about the use of probiotic?
So this is actually a very important question, and we have almost a dogma that has emerged that probiotics might be helpful for the prevention of necrotizing enterocolitis and sepsis. When we look at the studies that have been done, most of them have been very small studies. And then these small studies have been put together as meta-analyses. And it seems that every year we have a new meta-analysis on probiotics. Well, the question is, when you look at these meta-analyses, you see so many different probiotics being used. We can't decide on which one would be potentially really helpful. And a good prospective randomized controlled trial previously we had one from the United Kingdom, which involved 1,300 babies, which showed no difference in the development of necrotizing enterocolitis in the babies who received the probiotics versus not. Then recently, there's another trial called the Connection. I was involved with that, and it was 2,200 babies in 95 different neonatal intensive care units. The probiotic that was used was Lactobacillus reuteri, and it showed no difference between use of the probiotic and no probiotic in the development of necrotizing enterocolitis. But there was a difference in mortality between the two groups. The paper is not yet published, but we are working on that right now. So I think that this is a very interesting area, but the biggest problem that we have, and this is at least one lecture in itself, is that what we are calling necrotizing enterocolitis is such a heterogeneous diagnosis that it is not a single target. And whatever kind of study we do with necrotizing enterocolitis as an outcome is going to be highly problematic because the outcome is not one target. It is many different targets. So I hope that we might be able to talk more about that in the future.
Okay, thank you very much. One of our colleagues asked, while nasogastric tube is in, she said, we don't aspirate, but when the cover or the cap of the nasogastric tube is off or removed, there is a residual.
So there's a concern that sometimes there is a little residual. As long as the abdomen is soft, I am not worried about that little bit of a residual that is in the NG tube. I would not worry about it.
Okay, and you continue with the same amount.
Yes, unless there is something else going on with the baby. So, for example, if you're seeing increased abdominal circumference, any kind of change in the color of the abdomen, I would just continue with the same feeding.
Okay, thank you very much indeed. I think I will send you the questions by mail.
Sure, happy
Talk
to.
them, please. Thank you very much. Thank you for joining us for the third year or fourth year, I don't remember. And you have been to Cairo twice at least, or at least I have seen you twice.
One of my favorite places to go.
Yeah, one was Hippocrates and one in Shams, as far as I remember, isn't it?
Yes.
Okay.
Yes.
Okay. Thanks a lot.
Okay,
thank you. Thank you very much indeed.
Bye-bye.
Bye-bye.
Dr. Sameh, shall I make the last introduction?
Yes, please.
Okay. So we've been truly inspired with all the speakers, their expertise in the various topics, but this conference will have to come to an end. I have the pleasure to introduce our last speaker, Dr. Michael Narvi, who comes from Canada. He is the section head of the neonatal department at the University of Manitoba in Winnipeg. He has also had the role of medical director of the Child Health Transport System, and he is the past chair of the Canadian Pediatric Society on Fetus and Newborn Committee. So, Dr. Michael?
If you could activate my video, that would be good.